let's go to the other part, which is something called network meta-analysis, which is essentially trying to compare everything with everything, generating a comparison which goes through whatever is considered standard treatment to alpha glucosidase inhibitors, basal insulin, DPP4 inhibitors, GLP-1 receptor agonists, SGLT2, sulfonylureas, and so forth. Now, I remember the time when we have insulin, sulfonylureas, and metformin. Obviously, now the field changed completely. How do you navigate it these days? We show the data from this meta-analysis down the road, but how do you orient yourself and your patients in this maze?
Yeah. I think the most important thing is one needs to treat the patient and not treat the disease or treat the or treat according to an algorithm. So I think I'm going to go right back to basics, Roman. I think we need to do a history and a physical examination and evaluate the patient to say what are these patients' major problems and what is the goal of therapy. And I think if we say the patient is at high risk for cardiovascular kidney disease, it's really important that that person that has either a cocktail of cardio and kidney protective drugs as part of their regimen. So in addition to the ACE/ARB type drug, statin type drug, blood pressure control, etc., the non-diabetes focused things, I think there's a real place in that person's therapy for a GLP-1 receptor agonist, an SGLT2 inhibitor, or both. And everything we know shows that these work independently so that they can be combined, obviously one at a time. And the advantage of these new drugs, the SGLT2 inhibitor and the GLP-1 receptor agonist, is you get glucose lowering with added benefits. So the added benefits are cardio and renal protection. The GLP-1 receptor agonists lower glucose more, and they also lower weight more than the SGLT2 inhibitors. Patients, but they have different side effect profile. But I say they can be used together, and say they have both glucose and other effects. Metformin is an excellent glucose lowering drug. It's got a very...
Dr. Gerstein, let me jump into this because you are going now through the table effectively comparing different drugs. So let me, for the purposes of our listeners, explain that colorful area are those where we have strong evidence. Green is evidence for benefit, and reddish is highlighting potential side effects. And then we have this more neutral areas, which are effectively saying that those classes of drugs are neutral in comparison to, I don't know, standard treatments, or even slightly harmful. And what strikes me when I look at it is that we have those two classes of drug which has majority of greens, which means beneficial, and beneficial in terms even of all-cause death and cardiovascular death and myocardial infarction and non-fatal and admission for heart failure, and you can keep going. They also have distinct areas of untowards effect. But there is the whole slew of other medications which we were talking about, sulfonylureas and DPP4 and metformin and whatnot, alpha glucosidase inhibitors, which seems neutral in this area. So my overall question is, we started by talking about those two new classes of drugs. Where is the place for the, quote, old drugs?
Okay, so one of the big problems with this meta-analysis and with this table is that there is no column for glucose lowering, and there is no column for weight changes. Now, of the two, from a diabetes perspective, glucose lowering is a real benefit, because we know clearly that glucose lowering clearly reduces future eye disease and kidney disease and nerve disease and myocardial infarctions from meta-analyses that have been done independent of its other effects. So I think that is missing from this. I understand that they're looking at the hard clinical outcomes in this table, but I do think that's an important point to make. Well, as I said before, if the goal is glucose lowering, the person's at low risk for other problems, and there's no particular concerns about obesity and kidney disease, etc., then it's perfectly reasonable to start with a drug like metformin, because it will lower glucose, and it even can affect the course of diabetes. And in people who are in the pre-diabetes range, it does prevent future diabetes from happening. But if we're getting into a patient who has high risk for kidney, cardiovascular, or related diseases, heart failure for sure, then which is one important cardiovascular disease that people forget about asking. And then we're talking about the two top ones on this list, the SGLT2 inhibitors, especially if there's a heart failure concern, and the GLP-1 receptor agonists, and both of them have kidney effects. The SGLT2 inhibitors have more heart failure, kidney effects. GLP-1 receptor agonist has more cardiovascular, but also has kidney effects and heart failure effects as well. And you get the added benefits of weight lowering, etc. I'll go back to what I said before. When you look at it this way, it looks confusing. When you look at it from the prism of a doctor with a patient across from them, it's much easier. So what does this patient need? So you ask about, in my view, there's very little place anymore for sulfonylureas and meglitinides in our therapeutic armamentarium or arsenal, because we have other drugs that do the job at a better way. I think the DP4 inhibitors also, there's not a big place for them, unless your only job is glucose lowering, in which case they should be combined with metformin. But if you're talking about organ protection, especially people have some evidence of damage, the higher risk people, you should be talking about the top. Insulin always has a place. You need insulin for glucose lowering if the other drugs are not lowering glucose sufficiently. But interestingly, in type 2 diabetes, these other drugs are allowing us to use less meal insulin and allowing us to spend, if we're using insulin, it's more prandial or more, basal insulin, as opposed to meal-related insulin. But in the end, you got to treat the patient. What's their glucose level? What's their cardiovascular risk? Have you optimized their cardio protection? What's their kidney protective risk? Have you optimized their glucose levels? Have you optimized their A1C? And is weight an issue? And then I think you put it together and you can come up with a tailored regimen that is best for each patient, the one across from you. So you don't treat the disease, you treat the patient. You don't treat, the guidelines, you treat the patient. And the guidelines and the evidence informs the clinical judgment that you need to apply to the patient in front of you.
Okay, if I understand correctly, you have to pay attention to few things at the same time. You have to lower the glucose level and aim for reasonable hemoglobin A1C.
Yep.
And you have to look at the risks of renal and cardiovascular effect. You have to look at patients' weight and choose the drugs according to the patient's profile.
Yeah.
The higher the risks,
and quality of life and the ability to afford the medications, which is an important issue as well, of course. Yeah.
Right. So affordability and availability is an issue as well. I hope that your discussion does to me, does to our listeners what it does to me, which it clearly will help me next time I see the patient with diabetes to make decision about choosing the appropriate drugs. You mentioned affordability here. If I understand correctly, GLP-1 and SGLT2 would be more expensive than other classes of drugs, maybe except insulins.
Well, the SGLT2, people are always talk about cost, and obviously cost is extremely important. The nice thing about cost is that it changes every year. So SGLT2
Mm.
inhibitors are now going generic. So there are going to be non-proprietary SGLT2 inhibitors out there very soon. I think there already are some that actually are cheaper, right? And so the cost is going to change. I mean, you and I both remember when thiazides were expensive drugs, and beta blockers were expensive drugs, and ACE inhibitors were. So costs change.
Absolutely.
And as costs fall, they become, it becomes less and less of an issue. Even GLP-1 receptor agonists in the United States, the first GLP-1 receptor agonist that I'm aware of has become generic, or become a biosimilar. And so this is going to happen as well. But the reality is we're seeing the patient today, and cost is part of your assessment of the patient. And you have to prescribe a regimen that together it works because they can afford it. And so, that's part of the, clinical medicine.
Hertzel, it's a great pleasure to live with you through the revolution in diabetic management. We clearly lived through it. It's
Yes,
it's
we did.
similar to heart failure and revolution and rheumatoid diseases revolution. I mean, the world is changing, and thankfully for diabetic people, for the better. I really appreciate your every few year update for us and for McMaster Textbook of Medicine. My real appreciations and thank you.
It's always a pleasure. Thank you very much.